Welcome back. Let's dive in. Why are we so concerned about this excited or agitated delirium state? Because it can be immediately life threatening to the patient. Even if they don't have any external injuries, the internal metabolic storm going on can kill them. Let's break down some of the dangers. Hyperthermia. Patients often have extremely high body temperatures, sometimes 103 to 105 degrees Fahrenheit, or even more. This isn't just from external heat, it's due to a surge of metabolic activity and muscle exertion. Hyperthermia itself can cause organ failure. Think of heat stroke, where the brain and heart can malfunction at high temps. In excited delirium, hyperthermia is a common finding. Metabolic acidosis. All that extreme physical activity, thrashing, fighting, combined with possible drug effects, leads to a buildup of lactic acid and depletion of the body's reserves. The blood becomes acidotic, low pH. Metabolic acidosis can depress heart function and contributes to dangerous heart rhythms. It's frequently found on post-mortem analyses of these cases. Rhabdomyolysis. This is a big word for breakdown of muscle tissue. When someone struggles intensely against restraints or thrashes for a long time, their muscles can start to break down, releasing proteins like myoglobin into the bloodstream. This can cause kidney failure and electrolyte disturbances like high potassium. High potassium, hyperkalemia, is notorious for causing fatal heart dysrhythmias. Catecholamine surge. Imagine the fight or flight response stuck in overdrive. Adrenaline, epinephrine, and other stress hormones skyrocket. Heart rate and blood pressure go through the roof. This strains the heart tremendously and can precipitate dysrhythmias or myocardial infarctions, even in someone with no prior heart disease. Positional asphyxia or respiratory compromise. If the patient is struggling against restraints in certain positions, especially prone, they might not be breathing effectively. Combined with exhaustion, they will go into respiratory arrest. Providers who fail to appropriately assess their patients and put the patients in positions that are not conducive with life will ultimately kill their patients. All these factors together create a perfect storm where cardiac arrest can occur suddenly, often unpredictably. In many documented cases of what used to be called excited delirium, patients have died suddenly after or during restraint and struggle. The cause of death isn't always obvious on autopsy, it's this combination of factors leading to a terminal rhythm disturbance or asphyxia. The urgency here is that rapid control of the patient's agitation can save their life. If we can sedate them quickly, chemical restraint, and start cooling measures for hyperthermia, we may prevent that lethal cascade. That's why, once it's clear verbal calming isn't enough and the patient is in this extreme state, EMS must act decisively to restrain and sedate the patient for their own protection. Waiting too long or simply trying prolonged physical struggle can be fatal. We'll talk about how to do this safely in upcoming slides. Remember, an out of control patient in excited delirium is not just a crazy person causing trouble. It's a patient in imminent danger of sudden death if we don't intervene appropriately. You may have heard the term excited delirium in EMS or law enforcement circles, but you should know that this term has become highly controversial in recent years. For a long time, it was a catch all label for the kind of case we just discussed, those bizarre, agitated patients who suddenly die in custody. It even appeared in some EMS protocols and forensic reports. However, excited delirium is not an officially recognized medical diagnosis in standard classifications. It's not listed in the DSM, the Diagnostic and Statistical Manual of Mental Disorders, or in the ICD, the International Classification of Diseases. There's no universally accepted set of diagnostic criteria. In other words, it's more of a descriptive term than a rigorously defined condition. The controversy deepened because the term was often invoked in police use of force cases. Unfortunately, it gained a reputation as a convenient explanation for in custody deaths, sometimes being cited to attribute a death to the patient's extreme state rather than to any actions by law enforcement. Studies found the term excited delirium was being disproportionately used in cases where minorities died during police encounters. This raised huge concerns about bias and misuse. Critics pointed out that the concept had been based on questionable science and might serve to excuse excessive force. One news investigation noted it had become a theory that, despite discredited research and racial bias, was used to absolve officers in some deaths. In the medical community, there has been a strong pushback against the uncritical use of excited delirium. In 2021, the American Medical Association adopted a policy opposing excited delirium as a legitimate diagnosis, citing lack of evidence. They warned against using this term and especially against using sedatives like ketamine solely for law enforcement purposes without medical justification. The American Psychiatric Association has similarly disavowed the term. And very notably, just recently, the American College of Emergency Physicians, which in 2009 had a white paper that kind of supported excited delirium as a concept, formally withdrew its recognition of that term. In 2023, they stated their 2009 paper was outdated and no longer aligned with current science, explicitly saying the term excited delirium should not be used in medical contexts. They now talk about this condition as hyperactive delirium syndrome with severe agitation, emphasizing it as a medical phenomenon but avoiding the loaded term. What does this mean for us as EMS providers? Essentially, be aware of the controversy. Many EMS systems are removing the phrase excited delirium from their guidelines, or at least clarify its use. The focus is shifting to describing what is actually happening clinically, like severe agitated delirium, likely due to stimulant use, rather than labeling it excited delirium as a diagnosis. The term agitated delirium or simply describing hyperactive delirium is preferred. This keeps the emphasis on it being a form of delirium, which has many potential causes, that needs treatment. It's also more neutral language that doesn't carry the baggage that excited delirium does. In summary, know the term excited delirium because you may hear it. Some police or even older EMS personnel might still use it, but understand that it's controversial and imprecise. Always think about underlying causes and document what you observe: delirious behavior, threats to safety, need for sedation, etc., rather than just slapping on excited delirium as a diagnosis. And be cognizant that in the broader medical and ethical discussion, we're moving away from that term in favor of more medically defined language. Now that we've recognized a patient is in a state of agitated delirium or hyperactive delirium, what is our game plan as EMS? First off, treat it as a medical emergency. I know I've said that a few times, but it bears repeating. That means search for and treat underlying causes as best as you can in the field. Don't write off an agitated patient as just psych or just on drugs without considering things like hypoxia or hypoglycemia. For example, maybe the patient is combative because their blood sugar is 20. A dose of oral glucose, dextrose, or glucagon could be life-saving. Or maybe they're hypoxic from a head injury. Give high-flow oxygen right away. In reality, with a violently agitated patient, you might not be able to check a glucose or pulse ox until they're somewhat controlled. But keep it in mind and do it as soon as safely possible. Many guidelines suggest giving oxygen early because it can help if hypoxia is a factor and also pre-oxygenates in case we need to sedate. Follow your local EMS guidelines for behavioral emergencies or agitated delirium. Most EMS agencies have specific guidelines for handling these situations. These usually outline a stepwise approach: attempt verbal de escalation, call for police assistance, criteria for using physical restraints, and options for chemical restraint, like sedative medications, if you're authorized, usually given by ALS. Be aware that guidelines are evolving in light of the controversies. We're seeing some protocol language shift from excited delirium to terms like severe agitation or behavioral emergency with delirium. Regardless of terminology, the principles remain: ensure safety, calm the patient, and treat the cause. The primary goals on scene are to protect the patient and everyone around from injury and to get the patient under control so that we can provide medical care. Sometimes that can be achieved with verbal techniques alone. Many times it will require restraints and medication. Rapid sedation is often the turning point that allows definitive care, especially in true hyperactive delirium cases. It's worth noting, if you anticipate the need for chemical sedation, call for ALS backup early if they are not already on scene. As an EMS professional, you may not be able to administer drugs like benzodiazepines or ketamine on your own, unless you are a paramedic. So, if a patient is extremely agitated beyond what gentle restraint and talk can manage and administering sedatives is outside your scope, radio for an ALS unit immediately. It can take time for them to arrive, and you want that capability on scene sooner rather than later. While awaiting backup or as you initiate your protocol, continue to talk to and observe the patient. If there's any sign of a specific cause you can address, for instance, someone mentions the patient is diabetic, or you see an insulin pump, or the pulse ox you finally clipped on reads 75%. Do what you can to fix it. Give sugar, ventilate, etc. But never lose sight of scene safety. If the patient suddenly lunges or the scene becomes unsafe, shift back into safety mode and wait for reinforcements. Guidelines often emphasize using the least restrictive means necessary, but when those fail, you escalate appropriately. We'll discuss the physical restraint process and then the chemical restraint options next. If verbal calming fails and the patient remains a danger to themselves or others, physical restraint may be necessary. This is never a decision to take lightly. Restraining someone is risky and can be traumatic for all involved. But the indication is clear. When a patient's behavior poses an immediate threat of harm and cannot be controlled by less forceful means, it's time to restrain for safety. We restrain to protect, to prevent the patient from jumping into traffic, hitting their head on a wall, hurting bystanders, or attacking us. It's also often a step to enable medical treatment. For example, you can't start an IV on someone who's swinging at you. Remember, per our guidelines and ethical practice, we only use force to the minimum extent necessary to achieve safety. Plan it as a team. The ideal approach to a violent patient is having at least 5 people involved in the restraint effort, one for each extremity and one for the head/airway. In reality, you'll use whoever is on hand, often that includes law enforcement officers and EMS together. Designate one person as the leader. This might be you as the lead provider, a firefighter, or a police officer, whoever is most appropriate. The leader should quickly brief everyone. For example, all right, we're going to restrain this patient on the stretcher. Alice, you take the right arm. Bob, you take the left arm. Officer Smith and Officer Jones take the legs. I'll stabilize the head. On my count, we move in. Having a quick plan and clear roles prevents confusion and reduces the time spent struggling. Use a coordinated, swift approach. Often the best moment to act is when the patient is distracted or not looking directly at you, or sometimes right after a verbal interaction fails and you can tell the patient is about to fight. When the leader calls it, all team members should move in simultaneously, each controlling their assigned limb. Speed is important. The goal is to get control within seconds. Prolonged fights are dangerous for everyone involved. Each person should try to secure their hold such that the patient can't bite, scratch, or reach any weapons. If available, use soft restraints, like commercial ambulance restraints or soft leather or cloth ties on each limb. Avoid using things like handcuffs or zip ties if at all possible. Those are rigid and can cause injury. Plus, EMS guidelines often state not to use law enforcement restraints unless absolutely necessary. If police have already cuffed the patient, work with them to perhaps switch to ambulance restraints for transport, and ensure an officer rides along with the key in case cuffs need removal. Crucially, watch the patient's positioning. Never restrain a patient in a prone position during transport. Prone positioning, especially with hands tied behind the back and weight on the back, is a setup for positional asphyxia. The patient could suffocate because they can't breathe properly against the weight and position. Instead, restrain the patient supine or semi-fowlers on the stretcher if possible, or occasionally, if they're spitting or extremely unruly, lateral recumbent. 4-point restraints, both arms and both legs secured, are preferred for maximal control. Hobble ties or hog tie, tying hands and feet together behind the back, are expressly forbidden in EMS. It is too dangerous for the patient. Also, never sandwich a restrained patient prone on a backboard or stretcher with additional weight. Honestly, don't do this without weight either. This has caused asphyxia deaths. Keep them face up and monitor their airway. The moment the patient is restrained, immediately check their airway and breathing. Make sure in the tussle they didn't vomit or suffer any airway compromise. Check pedal and radial pulses to ensure cuffs or ties aren't too tight, cutting off circulation. Proper soft restraints should allow you to fit a couple of fingers under them at the wrists, ankles. Monitor vital signs as best you can. This might be just observing respirations and skin color at first. Ultimately, we want to monitor all vital signs with an emphasis on heart rate, pulse oximetry, and end-tidal CO2 if available. Assign someone to keep constant watch on the patient's face and chest to ensure they're still breathing okay. Never leave a restrained patient unattended, even for a second. Stay with them and continually reassess. Talk to the patient throughout. Explain that they are restrained to keep them safe, and that you're now going to take care of them. This can help reorient them as they, hopefully, begin to calm with sedation or time. In summary, physical restraint is a critical skill. Do it quickly, safely, and humanely, with an eye on the patient's airway and circulation at all times. In many cases of excited or agitated delirium, physical restraint alone is not enough. The patient may continue to thrash and endanger themselves, or the underlying medical issues, like hyperthermia, acidosis, will worsen if we don't calm them. This is where chemical restraint, in other words, sedative medication, comes into play. EMTs and AEMTs will not be administering these meds yourselves. That's the role of a paramedic or higher under medical direction. But all levels absolutely should understand the process and be prepared to assist. When do we use chemical restraint? Essentially, when a patient's agitation is so severe that they cannot be safely managed or assessed any other way. If the patient is a danger and continues to struggle violently despite verbal efforts and physical restraint, sedation is indicated to prevent them from further harming themselves or crashing physiologically. Also, if you need to perform critical interventions, like IV access for life-threatening issues or just to transport safely, and the patient's agitation prevents that, chemical help is warranted. The threshold for using medications has gotten lower in recent years for these extreme cases, meaning we err on the side of sedating sooner to avoid a deadly outcome, rather than engaging in a prolonged wrestling match, which could be more dangerous. Rapid sedation can correct the course and actually protect the patient's life. Common medications used by ALS for this purpose include ketamine. This is a dissociative anesthetic. It's become very widely used in EMS for severe agitation. Ketamine can essentially disconnect the patient's consciousness and quickly subdue even the most violent patient, often within a minute or two of IM injection. Typical doses for excited delirium vary widely based on service guidelines, but typically fall between 2 and 5 milligrams per kilogram. The benefit is rapid action and reliable effect. The patient usually goes into a dissociative trance, which protects their airway reflexes better than some other sedatives. The biggest issue with ketamine is when providers administer it but do not do good reassessments of their patients or put them in positions that are not conducive with ventilation, like prone. I think of it like the patient's consciousness has been pulled out of their body for a little bit. Because of bad press and a misunderstanding of the medication, ketamine has been at the center of some controversy, but medically it is recognized as an effective option for dangerous agitation. Benzodiazepines. Medications like midazolam, Versed, or diazepam, Valium, or lorazepam, Ativan. These are sedatives that calm the central nervous system. They are also commonly used, and many EMS guidelines include a benzodiazepine for agitation. Midazolam is often given IM or IV for fast action. Benzos help reduce anxiety, muscle activity, and can stop hallucinations to some degree. The downside is they can depress breathing and blood pressure, so careful monitoring is needed. Antipsychotic sedatives, for example, haloperidol, Haldol, or droperidol. Haldol has a long history of use for acute psychotic agitation, often given IM. It's slower onset, 10 to 20 minutes, so often it's combined with a benzodiazepine for faster calming. Droperidol has a strong sedative effect and works a bit faster. It's come back into favor in some EMS systems. These help specifically with the psychosis component. They can affect the cardiac rhythm, so patients need monitoring. The goal of chemical restraint is to quickly and safely tranquilize the patient, not to knock them out completely into oblivion, and certainly not to punish them. There is an absolute ethical line here. We do not sedate people for law enforcement convenience or as a punitive measure. Sedation is a medical decision. The NAEMSP position statement emphasizes this. Using pharmacologic management should be a healthcare decision made by EMS with medical direction, not to facilitate an arrest. The AMA similarly opposes using drugs like ketamine in a law enforcement setting without a legitimate medical reason. So, we give these medications because the patient's life or health is at risk due to their agitation, period. We document the medical necessity, like patient extremely agitated, at risk of self harm, not oxygenating well, required IM midazolam per protocol. After sedation, immediate and thorough monitoring is required. These patients should be on a cardiac monitor, end-tidal CO2, and pulse oximetry. Continuously monitor airway and breathing. Sedation can tip someone into hypoventilation or airway obstruction, especially if multiple sedatives or high doses are used. Be prepared to support ventilations with a BVM if needed. Also, monitor blood pressure. Some sedatives can cause hypotension. Place the patient on their side or semi-upright if possible once sedated to protect the airway. Vomiting is a risk as they calm down. Have suction ready. And because many sedatives, especially ketamine, can raise heart rate and blood pressure, keep an eye out for any emergent cardiac issues. This is why ALS presence is crucial. They can manage an airway or dysrhythmia if it occurs. Sedation should be enough to make the patient calm and manageable, possibly even fully asleep. Once that's achieved, quickly initiate any further treatments needed. Start IVs, check glucose, cool the patient if hyperthermic, give fluids if needed, and transport promptly. Sedatives like ketamine wear off in 20 to 30 minutes for IM dose, so you want to be at the hospital when they do, or have redosed or switched to IV sedation under medical control. Never assume one shot and done. Keep evaluating. In summary, chemical restraint is often the turning point that saves a patient's life in excited delirium by halting the struggle and metabolic spiral. Use it when indicated, use it judiciously under medical direction, and watch that patient like a hawk afterwards. Now let's talk a bit more about maintaining safety and dignity throughout this process. Through all these intense moments, we must keep in mind the dignity and rights of the patient. Just because someone is violent or delirious doesn't strip them of being a human deserving compassionate care. A few important points on ethics and legal aspects. Maintain patient dignity by using the least restrictive means necessary. This is a principle emphasized in guidelines. If you can manage with verbal techniques, do that. If you must restrain, use only as much force and restraint as needed to ensure safety. Nothing more. For example, once a patient is calming down, you might loosen or remove restraints as appropriate with caution to avoid undue restriction. Always explain to the patient, if they're able to comprehend at all, what you are doing, and why. We are holding you because we don't want you to hurt yourself. We will let go as soon as it's safe. Avoid any derogatory or mocking language. It might sound obvious, but in the heat of the moment, sometimes providers can get frustrated. Remain professional. This also means preserving modesty. If the patient's clothing came off and it's safe to do so, cover them with a sheet once they're restrained to keep them warm and dignified, while also allowing cooling if hyperthermic. Balance that. Legal consent. Patients in this extreme agitated delirium state lack decision making capacity. They cannot rationally refuse care because they often don't even understand what's happening. This falls under implied consent. The assumption is that if the patient were in a normal state, they would want life saving treatment. So you are legally protected in treating and restraining an incompetent patient to save their life. However, it's good documentation practice to note that the patient was unable to consent due to altered mental status and that interventions were necessary for safety. If family are present, you can explain to them why you're doing what you're doing to get their support. Avoid dangerous or punitive practices. Certain actions are absolutely off limits. Never use techniques that deliberately restrict the patient's airway, no chokeholds or knee on neck, etc. Those are not medical techniques and are obviously extremely dangerous. Never apply pressure to the chest or neck in restraint, as mentioned. No hog tying or prone positioning that could suffocate the patient. Also, never use weapons, stun guns, pepper spray, as an EMS provider. Those are law enforcement tools, and even officers have guidelines on their use. Our job once we're involved is medical stabilization, not enforcement. Ethical use of sedation. Reiterating this because it's important, sedatives are powerful drugs and must be used for the right reason. We give them to a patient who needs medical calming. If a police officer ever were to say, "Hey, can you give this guy something so we can arrest him easier?" The answer is no, unless there is a legitimate medical need. Fortunately, most law enforcement we work with understand this and will phrase requests in terms of the patient's welfare. "He's really struggling. Can you guys calm him down for his safety?" Just be sure in your own mind and practice that you are doing it for the patient, not as a convenience. This keeps you on solid ethical and legal ground. It's worth noting that in recent years, some high profile cases have scrutinized EMS use of ketamine on agitated patients at the behest of law enforcement. That scrutiny falls on whether it was truly necessary. So always be prepared to articulate the medical indications in your report. If it's indicated, do it and document it. If not, you have the right to say no. Your medical director has your back when you follow protocol and good clinical judgment. Training and debriefing. Because these situations are high risk, EMS agencies are strongly encouraged to provide regular training in verbal de escalation, proper restraint techniques, and the use of pharmacological agents. This isn't something that should be learned on the fly during a real call. Additionally, after an incident, it's good practice to debrief with your team. Talk about what went well and what didn't. Make sure any injured providers get care. Also, acknowledge the stress involved. These calls can be mentally and physically exhausting, even traumatic, especially if the outcome was bad. Many services treat a severe agitation call like other critical incidents and offer support if the crew needs it. Learn from each case so you're even more prepared next time. Treating an agitated delirium patient can test every skill you have: medical knowledge, physical coordination, team communication, and empathy. By keeping safety first, following protocol, and treating the patient as a fellow human in crisis, you'll navigate the legal and ethical complexities properly. We will wrap up this lecture here. Join me in the next one to go through case studies about what we have learned and how you can apply that knowledge in the field. See you then.